Welcome to the Patient Advocacy Show. I'm Dr. Michael Warner. In this episode, I will introduce you to inaccurate health records. This may be where your health record tells a story, but not your story. We will start with a hospital case presentation, then tell you about Dr. Hallway, then review what you can do to assure accuracy in your health record. Hospital case presentation. The September 15th, 2016 issue of Family Practice News feature report about electronic health records, EHRs, called Seeing Through a Glass Darkly by Drs. Chris Noti and Neil Skolnick. The article describes a hospital case presentation where a patient was recently brought in front of an audience of doctors and medical students to tell her story. The patient, wearing a gown and attached to an IV, sat in a chair on stage. She delivered a coherent and powerful narrative of her unusual signs and symptoms as they developed over a 4-month period of time. During the delivery, the patient welled up with tears. After she was finished, the conference staff then read the patient's story as written in the electronic health record. It was a different story. The documented health record, a legal document, a unifying tool designed to have everyone in the healthcare team united in understanding the patient who is seeking medical care, failed to describe the patient's story. In addition to the health record being inaccurate, the authors observed a thorough history would have detected multiple immediate family members of the patient with the same disease. The authors blamed the electronic health record as standing in the way of understanding the patient's story. They see EHRs as becoming a filing cabinet for mundane and trivial information. They quote another doctor who considers such records to be filled with total nonsense. They call for physicians to rediscover the patient in their story and not rely solely on the poor reflection of what they may find in the chart. It is worth noting that this published hospital case presentation is not a reflection of an EHR malfunction. The EHR did not mistakenly switch records with someone else. The EHR did not write a phony story about the patient. The electronic health record simply reflected the information that was entered by the doctors. Before we consider a few unintended consequences of an inaccurate health record, whether it be on paper or on the computer, let me tell you what a friend recently told me. Dr. Hallway. My friend is an obstetrician-gynecologist, an OBGYN. Dr. OBGYN got a phone call from the emergency room a few weeks ago at 2 a.m. asking her to come in the hospital and take care of a patient who delivered a baby 10 days ago and is now experiencing eclampsia. Some of you may remember hearing of eclampsia as toxemia of pregnancy. That term is no longer recommended. Eclampsia is a reaction that occurs in the mother, causing blood vessels to constrict, along with increasing clotting of the blood. It is a problem that can arise if there are problems with how the placenta communicates with the womb. This condition usually happens later in pregnancy, but it can happen even after the baby is born. Pre-eclampsia is when the patient experiences high blood pressure and protein in the urine. It becomes eclampsia when seizures appear. Dr. OBGYN did not recognize the patient's name and asked who delivered the baby. The doctor in the ER identified a family doctor who was the one who delivered the baby, but reported that she could not be contacted. And because Dr. OBGYN was on call, she was assigned the patient. When Dr. OBGYN arrived at the emergency department, she found the patient reaching for the stars and saying her baby is trying to attack her. This does not look like eclampsia, thought the doctor. To be sure, she ordered tests and started a low dose of magnesium sulfate IV. The husband was present, but the baby had been left with friends. The doctor declared, "We need to get the baby together with the mother. We need to consult social services and psychiatry." 3 days later, the mother and the baby were starting to bond. Social services developed a relationship and was making plans to visit her at home. Psychiatry was implementing a treatment plan. Everything was coming together. While Dr. OBGYN was at the bedside of the patient, the family doctor who delivered the baby appeared in the hallway. She waved to the patient and said, "Everything is okay, you can go home now." Dr. OBGYN ran outside the room to speak with Dr. Hallway. She explained the story of how the mother presented and how social services and psychiatry were working hard to get the mother and the baby to bond, and she expected the patient to stay in the hospital for at least another day. "Fine, you take care of it," responded Dr. Holloway. She then stopped briefly at the computer station and left. Dr. OBGYN finished working with the patient and later sat at the computer station to document the encounter into the electronic health record. When she was done, she wondered about Dr. Holloway. Sure enough, in the patient's electronic health record was a full medical encounter note by Dr. Holloway. Dr. Holloway described completing a detailed interview with the patient, along with a full mental status evaluation. The documented examination described deep tendon reflex testing of arms and legs, along with testing of the cranial nerves. The patient's story, according to Dr. Holloway, was that the patient was fine, everything was normal. Despite entering pages of testimony in the electronic health record, Dr. Holloway never asked the patient a question or performed any examination. The health records of a patient in the hospital case presentation and Dr. Holloway's health record notes are similar in that neither tell the patient's story. In both instances, the patients eagerly told their medical stories, yet both were misrepresented in the documented health record. In the case of Dr. Holloway, pages of notes were populated to reflect physician work that was never done. We want Dr. Marcus Welby, but we need Marcus Lemonis. What would the prophet say if someone misrepresented a client in a legal document? I know what he would say, but he'd have this look on his face first. It would go like, A recent medical article suggests doctors should wear Google glasses to capture what happened. It may be better if the patients wore the cameras. Some patients are secretly recording their office visits and posting them on online forums. Such videos, like the Family Practice News article, expose bad patient care. Though such recording is illegal without two-way consent in many states, it is only a matter of time before a video of an encounter is posted side by side with a documented health record. You can imagine, as per the hospital case presentation and with the phony note by Dr. Holloway, that the health record and the video will be dramatically different. The government and private insurance companies know that this is a problem. They are concerned about inaccurate information. In today's economy, they are particularly interested because they see an opportunity to get back money plus fines. Private insurance companies are adopting forensic computer technology to track the digital footprint and footsteps of health staff as information is entered into the electronic health record. Within 3 years, it will be standard protocol for insurance companies to audit medical records with these tools. The audits will also look back years, possibly discovering the records of the patient who was recently on stage at the hospital case presentation. Data analytics will track down Dr. Holloway. After all, how can a medical provider conduct a comprehensive history and physical and only be in the hospital for 12 minutes? I mean, the parking garage timestamp and the EHR computer login times will call Dr. Holloway's credibility into question. Plus, Dr. Holloway's description of the patient's story does not match the rest of the health record as reported by Dr. OBGYN, the psychiatric physician, and the social workers and the nursing staff. The federal government may not be as fast to implement forensic computer technology, but they have an advantage in cross-referencing suspicious health record documentation with medical provider federal income tax statements. In addition, the government is particularly sensitive when a professional knowingly documents statements into a legal document that are not correct. Dr. Holloway also creates problems related to medical necessity. Upon review of the records, the insurance company may deny coverage for the hospitalization and all tests done since the doctor wrote everything is okay, with pages of negative and normal findings. This may cancel the social service efforts to follow the patient up at home. It may also cancel ongoing psychiatric care. To make matters worse, based on Dr. Holloway's note, it looks like Dr. OBGYN is the one making up problems about the patient. By reading the medical record, one could assume that healthcare would be so much better if Dr. Holloway would just take care of all the patients. Dr. Holloway complicates how medical providers are evaluated. When administrators look at the data, Dr. Holloway is the superstar. She is efficient and effective. She can see patients quickly and her notes are superb. She establishes the benchmark for patient-centered care. According to professional coders, Dr. Holloway provides all the required details to justify a high level of service, thus meaning a high fee. Because coders are not present during the medical encounter, how are they to know that the doctor fabricated what is documented in the health record? When comparing Dr. Holloway with Dr. OBGYN, the choice is clear. Dr. Holloway is the champion. Perhaps Dr. OBGYN should be assigned to follow Dr. Holloway around and learn how to really practice medicine. The hospital case presentation is problematic as well. The authors write that a thorough history would have revealed multiple immediate family members of the patient with the same disease. This alludes that the patient could have been diagnosed earlier. How many tests and how many office visits were unnecessarily focused on the wrong patient story? I wonder what the patient, in both circumstances, thought about the disconnect between the real story and what is documented in the health record. For sure, if the patients did not read their own health record, then they would never know. I wonder what administrators thought about the disconnect of information at the hospital case presentation. How do they plan to remedy the problem? How are they auditing health records for accuracy? What are their plans to train and educate? Healthcare informatics technology is about to data mine the patient's entire health record. Beyond the diagnostic codes, big and small data analysis will look to the patient's story in the history and findings in the examination. Healthcare data analytics will give us clues to better diagnose and treat disease. How do you think Dr. Holloway's charts will impact the validity of data analysis? With Dr. Holloway at the helm, where do you think our health system is going? So where do we go from here? We do not have time to wait for government and insurance company investigation teams. Based on how we currently run our healthcare delivery system, within 3 years, Dr. Holloway will be chief of staff at the hospital, and Dr. OBGYN will either be dismissed or at least reprimanded. Worse yet, we cannot hope to understand our patients if the documentation tells some other story. It's amusing, but not funny, that we are paying taxes and high health insurance premiums while Dr. Holloway runs down the hall waving to patients in order to generate an income. As customers of healthcare, our patients deserve better. Our first step is to educate. I invite you to participate in our free Patient Advocacy School online training modules. By participating, you will gain the perspective of a doctor, a patient, a certified professional coder, and a health policy fellow. If you participate in our modules close to when this video is first posted, then you will be part of our beta run. Soon, we hope to achieve expedited Internal Review Board IRB approval so that the data captured while you participate can be published in medical research papers. We provide this link here and on our website and our Facebook page. The website link will bring you to an enrollment page that will ask you to enter a first and last name. Please make up a username for the first name and enter your digit zip code as the last name. Please remember these two names in case you get disconnected. We will not know your identity and we will have no means of knowing what name you entered. Thanks to technology by PlayPosit, the short video series includes 3 questions at the beginning and end of each video. These questions will test knowledge and how you feel about certain topics. I will report these results to you in future episodes of this show. The Patient Advocacy series will also be available on YouTube, but you will not be able to answer questions as it will be in view mode only. YouTube will, however, like this show, allow you to leave comments at the end of the video. In addition to the free online training, we also offer a free audiobook version of Rise of the Patient Advocate, Healthcare in the Digital Age, which was published on Amazon in 2015. We hope you find the information informative and helpful for you as you become your own patient advocate. This series is run by Patient Advocacy Initiatives, a nonprofit organization registered in the state of Pennsylvania, with focus on teaching you how to obtain, read, understand, correct, contribute to, and co-author your health record. Let's get everybody on the same page when it comes to understanding the importance of healthcare documentation and the way the health record is organized. I believe that with knowledge, we will all understand what should be documented in the health record. We do not need to make new laws. We only need to learn and follow the ones already on the books. In Inaccurate Patient History and Examination, will lead to an inaccurate diagnosis with a potentially dangerous treatment plan. Inaccurate records can cause treatment delays and allow for progression of disease, sometimes to the point where it's too late to help. Let's empower patients to be their own patient advocate. Let's foster a strong patient-provider relationship where the patient is heard and understood. Let's improve the accuracy of the health record, whether it be paper or electronic. Let's recognize good doctors for their excellent patient care and let them set the standard. We have tolerated what is written in the health record as a joke. Click some buttons, make up some story. It doesn't matter. As a legal document, your health record matters just as much as a cash register receipt, a credit card statement, or a credit score. If the cash register receipt is incorrect, you may lose some money. If your health record is incorrect, you may lose your life. We can do better. We should expect better. Let's start with some education and training. Let's welcome the digital age of healthcare and expect great gains in healthcare quality, cost, and satisfaction. First, let's be sure that our health records are accurate. Let's treat the patient's subjective story as valuable information worthy of documentation. Thank you for watching the first episode of the Patient Advocacy Show. I would love to read your comments on this episode. Also, please visit our Facebook page. I encourage you to participate in the training series and hope you enjoy the audiobook. I will see you at the next episode where we'll use the patient's subjective story to reduce the advancement of ovarian cancer. Best of health to you and your family. I'm Dr. Michael Warner.